So with that said, I'd like to now move to the next speaker, Dr. Mikhail Kosiborod, who is a cardiologist here in Kansas City. He is the director. He's a professor of medicine at the University of Missouri, Kansas City, and the training program director of the Outcomes Research Postdoctoral Fellowship at the Mid-America Heart Institute at St. Luke's Hospital. He's published a number of really important outcome studies in cardiovascular medicine, and I know has a perspective on this research and how it will improve care.
Okay, well, thank you, Dr. Payne, for this kind introduction. I hope everybody can hear me. Okay. Here we go. And I do have a number of disclosures. I don't have a disclosure slide, but I can assure you that none of my disclosures have any relevance to the topic I'm actually going to speak about. Another, I guess, one disclosure I should make is that the work that I will talk about in the next few minutes is done by, certainly not just by me. In fact, a lot of this work was done by my close friend and colleague, Dr. John Spurtis, who I work with, and others at St. Luke's Mid-America Heart Institute Cardiovascular Research Program. So I certainly deserve very minimal credit for the specific example I'm going to show you, but it exemplifies what we do in the Heart Institute very well. So I think Dr. Payne already mentioned the IOM report on the learning healthcare system, and I put in, I guess, some of the key aspects of the learning healthcare systems that were outlined in the report. And the three, I guess, critical concepts from my standpoint that I will spend some time talking about is to create a new clinical research paradigm, which really, if you read the report, means that the new clinical research paradigm is to move clinical research closer and make it more immediately relevant to the clinical care that's being delivered. To create... Huh?
I'm sorry, she didn't get this.
Oh, okay. No problem.
Sorry about that.
Okay, here we go. The last two, if you do go by modified. The second one is clinical decision support systems, which means that, again, the idea here is that the clinical practice is moving at such a quick pace, and the level of decision-making is becoming so complicated, and there are so many data points that you need to incorporate in your decision-making that it's becoming nearly impossible for an individual clinician to incorporate all of that in the time that you need to incorporate it to make a critical decision-making without the support of these novel tools that I will talk about. And you also need to have tools for database linkage, mining, and use. And so essentially the idea here is how do you take large databases that we have created in cardiology, and I'm a cardiologist, so I'm going to give specific example to cardiology, but it could be anything in medicine. How do we take these large data sets, create, using the information, these clinical data sets, create decision support tools, and then incorporate these decision support tools at the time you're delivering care so you can make the right decision for the right patient at the right time. So, and again, just to reiterate, this is a critical challenge, right, which I think the report outlined, which is that you want to deliver personalized, evidence-based medicine at the point of care with the purpose of improving patients' experiences with care, improving the use of appropriate treatments, and creating optimal outcomes. And ultimately, another important issue that Dr. Payne outlined as well is that with the limited resources, which may become more limited in the future, also try to do it in a cost-effective way so we lower the cost of care. And hopefully I'll be able to convince you that it is possible to do with this learning healthcare system concept. So in my view, this is just my personal view that I know John shares with me, but hopefully we can agree on what the learning healthcare system is. From an outcomes researcher standpoint, the first step in developing a learning healthcare system is to actually understand what it is that we're doing or what outcomes we are producing. So you actually have to, I guess it's Winston Churchill said that regardless how brilliant the strategy, you need to look at the results occasionally to understand what it is that you're doing. So if we don't look at the results of what we're doing, we will have no idea where we're going and what we can do to improve what we do. So first you have to look and define your outcomes. Then you need to scrutinize practice to figure out why you're having the outcomes that you're having and is there something that you can do to improve it. Once you identify what the possible improvements are, you need to come up with ways to actually change what you do to improve the outcomes. So you need to intervene. As you intervene, probably other new concepts will come up that can make your interventions even more effective. You implement the improvements, and then a critical step is to come back to the loop, which is after you implement the improvements, you need to reanalyze what your outcomes are to first make sure that what you think you did, you're kind of assuming that what you're doing is going to improve care. Well, you have to demonstrate that what you did actually did improve care, because what you think is going to happen and what actually happens in real life is not always the same. So you have to make sure that you prove to yourself and others that what you did improved outcomes, and then the loop continues. The fact that you improved something doesn't mean that you can't improve even more. So I'm going to, I think one picture is worth 1,000 words. Also, one real example from real life with a real issue, I think, can make the point better than anything else. So I'm going to specifically talk about how we incorporated these concepts to try to improve care for the patients with cardiovascular disease. And the example I'm going to use is trying to reduce the bleeding complications in percutaneous coronary intervention, or PCI, which is a very common procedure when we essentially insert a thin catheter in a patient artery going to the heart when they're having a problem with coronary disease where they have a blockage in one of the heart arteries, and then inflate a balloon and place a stent to try to essentially open up the blockage. And that can be done in a setting of acute heart attack where it's actually life-saving, or it can be done in an elective setting where it typically is done just to improve patient symptoms. So these procedures are very common. Millions of people undergo this procedure all over the world every year. And bleeding is one of the most common complications of it. So it's actually the most common non-cardiac complication. It clearly increases the risk of death, recurrent myocardial infarction or heart attack and stroke. It prolongs patients' length of stay. And it markedly increases the cost of hospitalization, somewhere in the tune of $6,500 to $8,500 when somebody has a major bleeding complication in the setting of this procedure. And the American Heart Association, American College of Cardiology, or professional societies have recognized that this is a real important problem. And while there is not a huge amount of consensus about what to do to improve or reduce the risk of complication, at least the professional societies recognize that we should be evaluating patients for their risk for bleeding. In fact, there are certain things we can do to reduce the risk of bleeding. There are several interventions that could be considered. We could use a radial artery, which is artery in your hand, instead of the one in the groin, which is associated with much lower risk of bleeding. You can use a medication called Bivalirudin, which is one of the medications that have been around for a few years. It's typically associated, or in fact, has been proven in clinical trials to cause much lower risk of bleeding than heparin, which is another medication that's used commonly. You can use what's called a closure device, where you try to close the artery after you're done with the procedure. So that may reduce the risk of bleeding. And you can also consider keeping the patient in the hospital longer for observation if you think they're at higher risk for bleeding. All of these things can be used to try to reduce the risk of bleeding and complications. And this is a critical point here, which is, and I'll talk about it a lot more as we go on, which is the risk stratification of patients is very, very important. Because if any of the therapies, any of these procedures, such as radial approach or medication uses such as Bivalirudin, or use of closure device or inpatient admission, all of these things can be used in everybody, but then if you use it in everybody, you're really using them in a very kind of unsophisticated way, which wastes a lot of time and energy and resources, because patients who are at very, very low risk for these complications are going to do fine anyway, and they probably don't need any of this. And the patients who are at very high risk probably should be using all of these things to try to prevent a complication. And so the idea here is that if any particular intervention like bivalirudin, which has been shown in clinical trials to reduce the risk of bleeding, if it has a constant relative risk reduction across a patient population, so for example, let's just say that a treatment X reduces the risk of bleeding by 20% in a clinical trial, which means that that's across a population. Those patients who are at a very low risk versus very high risk are going to have very different absolute reductions in risk. So somebody who at very high risk is going to have much greater benefit from a treatment than somebody who's at very low risk. So that's kind of a critical concept to keep in mind. So let's review what, it's one set of projects that we did to try to use the data that's been collected, develop a clinical decision support tool, and then implement it at the point of care to try to improve care and reduce complication rates. So first, you have to start with defining outcomes, as we've outlined before. And scrutinized practice is what you need to do to both define outcomes and try to figure out what you're going to do about it. So this is a paper that was published in JAMA several years ago by Steve Marceau, who is one of the interventional cardiologists at the Heart Institute, and several of my other colleagues. And the idea here was to show the following, which is specifically concentrating on the bivalirudin use, which is, again, one of the strategies to reduce bleeding. And the idea here was to show that the concept I just mentioned, which is if there is an intervention that reduces the risk of complication, the absolute risk reduction you're going to get is going to be much greater in patients who are at higher risk. So if you look at patients that are at low risk, moderate risk, and high risk for bleeding on the x-axis, and then actually look at the risk of major bleeding with and without bivalirudin, with bivalirudin being in green, you see that all three groups get the same relative risk reduction, roughly, about half the risk of bleeding. But these patients here, they have less than 1% chance to bleed anyway, and so it doesn't make a huge difference going from 1% to 0.5%, whereas these patients who have a 6% risk of bleeding, which is very high risk, would have a much greater absolute risk reduction. And if somebody's got a 10 or 20% risk of bleeding, they would have even greater risk reduction from this particular medication. So that translates in what we call a number needed to treat. That's just another way of kind of stating the same, which is how many patients would you need to treat to reduce to prevent one complication, to prevent one bleed. And so in a low-risk patient, it would be about 227 patients that you would need to give this medication to prevent one bleeding event. And remember, this medication is very expensive, okay, not available generic. In a moderate risk, it would be about 97 patients that you would need to treat. And in a high risk, there are only 42 patients that you would need to treat to prevent one bleed. So a really marked difference when you particularly think about good use of resources certainly would make a lot of sense to try to use this medication preferentially in patients at high risk. It also translates into costs. And the reason for that is because when you have to treat 227 patients to prevent one complication, you're going to end up wasting a lot of money. And so for our hospital, and this is specific to St. Luke's, for every patient we treat who's at low risk that we give bivalirudin to, the hospital ends up spending $705 for each of those patients. In the moderate risk patients, because you prevent a bleed that's very costly, even though the medication is important, there are cost offsets, right? So you end up saving $461 per patient when you use it in patients at intermediate risk. And in patients who are at high risk, the hospital ends up saving about $1,500, almost $1,600 for every patient that you use it on. So despite the cost of a medication, it's not only cost effective, but a huge cost saving strategy to use it in patients who are at high risk. And you end up losing money when you do it in patients at low risk. Now, this again is one of these kind of eye-opening experiences, and we see it in outcomes research all the time, but I think many get surprised when you show this exists, which is you would think that when the physicians would intuitively know who is at low risk, intermediate risk, and high risk. That somehow, through our medical training and experience, we would be able to identify these patients all the time, and we would be right, if not all the time, the majority of the time. And therefore, because we know this concept, which is that the same relative risk produces different absolute risk reductions in low risk versus high risk patients, that we would preferentially treat patients at high risk with the treatment that's most likely to benefit, and treat patients at low risk less commonly with that medication. In fact, it turns out that it's the opposite. So we actually, as physicians, don't do a very good job at identifying patients at low risk, moderate risk, and high risk, and we don't apply it in a rational way. The treatments, in fact, we see this is just one example where we actually looked and tried to figure out what happens in real life, and what we see is that Bivalirudin use here on the x-axis and a percent of patients being treated with it, you see that more patients were treated with Bivalirudin who were at low risk for bleeding than at an intermediate risk and high risk. And this is something that's called the treatment risk paradox. And we see it across specialties, across clinical conditions, time and time again, where patients who are at the highest risk and get the most benefit out of treatment are also the least likely to be treated. So the question is, what do you do about it? The goal here, clearly, what we want to do is that we want to reduce the risk of bivalirudin in low-risk patients, and we want to increase it in intermediate and high-risk patients for all the reasons we just talked about. So the next step is to actually try to intervene to improve practice. And I can tell you that this treatment risk paradox has been plaguing outcomes researchers and clinicians for a long time, and it's very, very difficult to understand why this happens and what to do about it. And in our view, one of the ways to deal with it is to actually take data from large databases and produce these decision support tools so that clinicians can know at the point of care who is low, intermediate, and high risk, and actually see graphical data of how much risk reduction they can produce with using certain therapies. So again, the same kind of idea from a slightly different angle, which is when you have a clinical trial, what clinical trial typically will show is that there is a treatment difference between treatment A and treatment B. But all you will get from a clinical trial is the average treatment benefit or harm, whatever that may be, across the entire population. But you know that what actually happens in real life is that some of these patients in the clinical trial will have a really good outcome, some are going to have an intermediate outcome, and some may actually be harmed by the treatment, even though overall treatment is very effective in improving care. So the idea here is, how do you try to target the treatment that is beneficial to the group that's most likely to benefit from it? Again, same kind of idea. And the way that you do it is you take large data sets that we have assembled and spent a lot of time, effort, and money to assemble in cardiology, and then try to apply develop prediction models from these databases, try to create prediction models to actually show clinicians who is at high, intermediate, and low risk so that they can apply treatments accordingly. So what we did actually was take a database that's called ACC NCDR Registries, stands for American College of Cardiology National Cardiovascular Data Registry. It was one of the first large cardiology registries that really transforms the quality of care, cardiovascular care in this country. And most hospitals, not all, but majority of the hospitals in this country actually contribute patient data to this registry, which is de-identified. We are one of the analytic centers for that registry. There are 3 in the country, we're one of them. And essentially, the general reason why these databases were developed and why these predictive models are being built traditionally has been to understand the quality of care that's being delivered and then benchmark it and actually report the data back to the centers that contribute the data to the registry. So the idea here was that the data is being generated, you're going to essentially tell the sites how well they're doing and how well they compare against their peers. And then by doing that, you actually will improve care because centers will compete with one another and they will want to be better than others, not worse than others. And it's definitely working and it's making an impact. But one of the paradigm shifts in our view was that this creation of this predictive model should not just be used for benchmarking and feedback back to sites, but should be used prospectively to improve health by creating these clinical decision support tools. And John Aspertus, who I mentioned before, has created this novel IT solution which is called PRISM. The idea of ePRISM is to take these complex prediction models and translate them into clinical care at the point of care. So ePRISM, what it does is it takes a prediction model that we spend a lot of time thinking and developing. And as you can see on the left, these prediction models are extremely complicated. So there is no way, and it wouldn't be reasonable to expect a clinician who is delivering care to a patient in clinic or in a hospital to try to incorporate 27 different variables and compute somebody's risk with one treatment versus another. It's just never going to happen. And one of the reasons why these prediction models have been developed and published in the best journals in the world, but never used clinically, is because they're not practical to use clinically. However, if you have this novel IT platform and you actually transform this model without any input from clinician herself or himself, and essentially pulls the data out of the electronic medical record, or have a practice extender, a nurse or a nurse practitioner or somebody else input the data into the computer, and then at the point the physician is about to start a procedure, you actually show them the data that may have an impact, and they may actually use it. So the first application of this that John actually did was to try to transform the informed consent document. And I know we spent some time talking about informed consent, to try to use these models and this ePRISM tool to transform the informed consent process. And the problem with informed consent, as we all know, is that typical informed consent, including the ones that we used to use for the PCI procedure, was this very formal, impersonal kind of call document that was written at very high level in legalese. It was very vague. And provided absolutely no educational value whatsoever, and truly did not inform patients about what it is that they were about to have. By using these prediction models and transforming the informed consent documents through ePRISM, we were able to generate this new consent document, which actually talked about the procedure specifically, not just a general procedure you're about to undergo, and then you just fill in the blanks what the procedure is, and then there is no information about it. In a typical consent document, this is a consent that's specific to the procedures that actually talks about what the patient is going to have, what the potential benefits and risks are, and instead of talking about general benefits and risks, it then takes the patient's individual information and provide personalized risk assessment for the patient. So it's not, when a patient asks me, doctor, what is my risk of having this procedure? The typical response would be, on average, patients who undergo this procedure have, 5% risk of bleeding or, 3% risk of kidney injury. Whereas here you can actually provide a very personalized assessment based on patient's variables using these complex models. But these models are run by, kind of in the background. Nobody actually has to compute them in their head. So we developed this novel consent document, and we've implemented not just at the Heart Institute, but we did a multi-center study to try to implement it in other cardiac catheterization laboratories. And it's not just us saying that this is really transformative in terms of how care has been delivered, but others, including Henry Tink, who's a good friend at Mayo, an interventional cardiologist, who felt that, and Mayo was one of the 9 centers where we implemented this, that this had really markedly improved care of the consent process. So based on this kind of first initial experience, the idea was that if we take this platform and we show the physicians at the time they start a PCI procedure, before they started, what the patient's individualized risk of bleeding is, and then what kind of benefits they can expect from treatment, that their treatment patterns will change. And instead of using most of this medication in low-risk patients, maybe we'll actually start doing it in more in high-risk patients. So did that actually happen? So we did do that at the Heart Institute. And essentially providing this kind of information to clinicians at the time they start the procedure, what the individualized bleeding risk is from a procedure, not just general risk. And what we saw after the implementation was quite dramatic, which is that we were able to reverse the treatment risk paradox by providing this clinical decision support tool at the point of care. So you see, pre-implementation, we had the same risk treatment paradox as we saw nationally, which is the patients at the lowest risk were getting the most of the medications that, again, is quite expensive. And after the implementation, it completely reversed. So the patients who were at the lowest risk were getting less, and the patients at the higher risk were getting more. So this is actually one of the first examples of this reversal of the risk-treatment paradox by implementing complex models through this novel IT platform at the point of care so the patient can get the best care that is available to them. Now, ideally, you would actually see, maybe 5% use of bivalirudin in the low-risk patients and like 95% risk of bilirudin in high-risk patients. So this is far from ideal, but it's certainly a step in the right direction. The next question was, and by the way, not just this, but if you actually look at our bleeding rates across the institution, before and after the bleeding model was instituted, you can see that there was a significant improvement in bleeding rates as well. So the next question was, well, this is at our institution. Can we actually replicate it elsewhere? And so we did a study, John did a study at 9 centers across the country. And it was the same kind of idea that we're going to implement PRISM for the bleeding prediction model and then measure outcomes before and after. And one of the criticisms potentially was, as we were going through the review process on the study, was that there are secular trends, meaning that institution may be implementing things that can reduce bleeding rates at the same time that have nothing to do with PRISM. So how do you know that it's the PRISM that's doing it, not something else? But because it was done through collecting data through National Cardiovascular Data Registry and American College of Cardiology, we actually had data from the rest of National Cardiovascular Data Registry from hundreds of other hospitals over the same time period, so we could actually compare that. And what we saw is this. In the centers that actually implemented PRISM, so on the x-axis is the bleeding risk, on the y-axis is the rate of bleeding, and you saw exactly what you would have expected if this intervention was successful, which is you had significantly lower rate of bleeding in the centers after implementation of PRISM as compared to before. And odds ratio was about 0.55, meaning that we reduced the relative risk of bleeding at this size by about half, which is pretty dramatic. And again, just to make a point, comparing to all the other hospitals that were in NCDR at that time, the other hospitals, which is 1,135 of them, had some reductions in bleeding over the same time period from other quality improvement processes that we're doing, about 10%. And it was close to 45% over the same time period in sites that implemented PRISM. So really a huge effect of this clinical decision support tool. So as always, there are new opportunities to improve. We're certainly not planning to stop. Just to show you some of the opportunities that even in the 9 centers that we studied that actually improved dramatically by implementing this tool, you would normally expect when looking at individual physicians doing these procedures that all of them over this time period would actually have a curve like this, which is they would start using, at the end of the trial, they would start using the treatment most in patients at the highest risk. When we actually looked at these curves, they looked like this, which means there were plenty of doctors who improved dramatically. There were plenty of doctors that didn't change, and some doctors that actually got worse over the same time period. So while, again, the average effect was clearly positive, clearly in the right direction, and it truly transformed care, this is one of the reasons why we're not seeing 5% in the low risk and 95% in the high risk. We're seeing like 25% in the low risk and 45% in the high risk because of this. So the range was between 1 and 100% of using this treatment in the high-risk patients. So there's clearly further work to be done to improve consistency and safety of care, and there's no question that this will never stop, and hopefully it shouldn't stop because there are always ways to do better. So I think this is about it. I guess I had a summary slide. I'm not sure why it's not here, but essentially what I was going to say at the end is that this is one example of what can be done in a particular treatment area. We're actually taking this IT platform and using it to predict individualized risk and direct the most appropriate care to the appropriate risk patients across all kinds of treatments and specialties. So we're actually doing it in heart failure. We're doing it in electrophysiology, which is when we treat complex arrhythmias and implant devices to try to prevent arrhythmias or treat arrhythmias. We're actually doing it with weight loss. We're doing it in diabetes and cardiovascular disease. So the applications of this are literally endless.
Thank you.
Thank you.
Thank you. That was a great talk. So you got quite granular there in terms of showing how in a specific disease process using these outcomes-based research methods that you actually, the system learned, right? You went from a bad, ineffective practice to moving in a direction of better practice, and even actually showed not only you changed behavior of the clinicians, but you actually got better outcomes because bleeding. So that's kind of what we're talking about here, right? That's where we want to go, and it's a good segue into our next speaker.